You girls will laugh at me. Good morning from the VA, first off. Secondly, this is the third attempt I've had at trying to video this. My phone's been getting all these crank calls and children wanting things when they're supposed to be homeschooling. So it's been quite an interesting morning. So this is my third attempt at trying to do a video recording for a case study for you guys, if a patient we would be seeing if you guys were here. Miss you, and good morning from the Boise VA. I know you recognize the room. We miss you and hope that you can get back into the clinical setting very soon, because I miss you guys. So I just did an S-bar on a patient that we might be seeing, and I'm sorry about the video way I'm doing this, but so far, so our situation, we know that's the first part of what we're going to look at. We have a 70-year-old male. He was admitted into ICU bed 3 for pneumonia and rule out COVID. So that's our little bit of information for our situation for our patient. Our background, he is a T3 paraplegic, status post motor vehicle accident in 2017. He has a tracheostomy tube, so it's a Shiley size 7. We'll talk a little bit about that. He has an indwelling Foley catheter and a PEG tube for his feedings. He also has a history of atrial fib, chronic UTI, and mucus plugging. Those are little light bulbs going on in our noggin as we get this information. It's a history of ETOH, and he stopped smoking in 1998, but we don't have any pack year history, so we don't know if there is any underlying lung disease. Here's his admission information. So he comes to us, he's hypoxic, he's 84% on 10 liters through his trach mask. His heart rate's 124, his respiratory rate's 22. So he's hypoxic, tachycardic, and a little bit tachypnic, not too bad. But we don't really know much about what his baseline is. So we'll look at that and find out, but we know he's hypoxic on a lot of oxygen. Is his heart rate elevated? So some things we're thinking about, is his heart rate elevated because he's hypoxic, or is he an AFib? We look back here and we see he's got a history of atrial fibrillation. So we want to know, is he tachycardic? Is he an AFib with this heart rate of 124, or is he tachycardic because he is hypoxic? So all these light bulbs are going on for us as we see this information right here. Okay, his abnormal lab values on admission. So his white blood cell count was 10, red cell count 3.29, hemoglobin 9.5. In his white cell differential, his neutrophils were elevated. In his chemistry, his urea nitrogen was slightly elevated. His proteins are slightly elevated. His albumin is slightly low. His troponin is 130. Troponin T was very, very high. This is well above normal. His sputum culture, which luckily this patient has a tracheostomy. So getting a sputum sample is a little bit easier when they have that. So we showed, they showed 3 bugs were found in there. So they suctioned him in the emergency room, got a sputum sample. This is extremely helpful for determining what antibiotic we use for this patient. He has a little bit, he is a little bit febrile. He came in at 99.8, and I didn't write that down, but that's his information. So he's a little bit febrile, tachycardic, tachypnic, and hypoxic. So we're trying to think immediately of things we can do from an RT perspective for this patient with an artificial airway. When you have an artificial airway, you bypass your body's ability to heat, filter, and humidify all your air naturally, so we have to do it through an external source of humidification. So automatically we see mucus plugging as part of his history up here, and we know that might be what's causing this issue, so we know there's some things that we need to do right away. Okay, his white cell count's just slightly elevated, but it is elevated. Couple that with the fever, the hypoxemia, and the tachycardia, we kind of think immediately we better get a sputum sample, because we think this could be lung related. Also, a patient with an indwelling Foley catheter can always have this, the history of the chronic UTIs. So they did a urine culture and a sputum culture. And in the sputum, this is what they grew out. They found 3 bugs, made it very specific to, they did a specificity with the antibiotics so that they could see what antibiotic could specifically kill these bugs. This is pretty common for a patient with chronic trach. A few of these things. His BioFire panel, and I'll show you guys that on the computer. So this checks for a bunch of different viruses and stuff, 15 or 16 different ones. And I know we were doing these when you guys were here, so you may remember some of the things that it checked for: influenza, a lot of the different strains of the coronavirus, a few other things. And then luckily his COVID-19 came back negative as well. So these are kind of some lab values on admission and a little history for him. Okay, so the other thing this patient has that's very interesting, and I'm going to kind of try to show you guys that. I'm shaking, huh? So here are his ventilator settings, and I'm going to go back over into the computer and put this down so we can talk about this. He's on nocturnal ventilation and daytime supplemental oxygen. So we'll talk about that. First, I want to show you his admission x-ray. So here is his admission x-ray, and I'm trying to figure out the best way to get that on there for you guys. So what you'll see here is a fair amount of hardware. This is from his motor vehicle accident. He's had a sternotomy, obviously. These are, this is a very interesting procedure they use when you break a bunch of ribs or you have a flail chest. And this is very fun to YouTube and watch that, how they do that and how effective that is at replacing the ribs where they need to be. Some things that are concerning to us right off the bat is, do we see this left costophrenic angle? Is it sharp like this right side? We have a little bit of a costophrenic angle over here. We don't see a costophrenic angle over here. So we're not sure, and we can't tell very well if the heart border comes down, if there's a pleural effusion that's blunting the costophrenic angle, or if there's an infiltrate in this left lung that's causing us to not be able to see that costophrenic angle. So a lot of different hardware. There's not a lot of rotation in this film. It's a good x-ray. So we're looking at it. The trachea tube, whoops, hold up. Don't close me out. So the tracheostomy tube is right midline and patent. What another line we can see, lines and tubes, is what we're looking for next. Coming in here is your oxygen tubing, and then the trach mask around here. So he was getting 10 liters a minute of oxygen through here into this. And so some things we're thinking about right offhand are that, okay, I'm gonna turn this thing around so I can talk to you guys. Okay, there we go. So some things we think about right away with the fact that he's getting 10 liters a minute through this trach mask is that's a lot of oxygen. Oxygen's a very drying gas blowing into an artificial airway. So we've bypassed his body's ability to naturally heat, filter, and humidify that air he's breathing in, because that's what our nose and all that, this upper airway stuff is supposed to do. So we're bypassing our body's ability to do that. So we need to get him on some humidity right away, especially when we see a chest film like that. We see the hypoxia, we see the fever, the hypoxemia, the tachycardia, and then this x-ray where that left side is pretty gobbly gooed up. Okay, so his first day, he came in, they put him on a heated trach mist, and they decided to suction him, of course, because the first thing we're thinking about as respiratory therapists when we get a presentation like this and a presentation like that is we got to get in there and get that snot, sputum out. So secretion clearance therapies. What can we do for this patient for secretion clearance? We have an airway, so we have an easy way to get down in there and get it. So we can suction him. And some other things you're thinking are, we got to humidify that air, we got to suction those secretions out, and some other airway clearance therapies that we know. Something we have to consider from this patient's background is he's paraplegic. So, how is his respiratory muscle strength? Is he able to get a really deep breath in and effectively cough out? Do we need to help with the deep breaths in? And do we need to help with the cough out? So we used to do a lot of quad coughing, which is fun to look up if you're curious about how we used to do these kind of things. And now they have something called a cough assist. So for this patient, based on his respiratory muscle strength and his clinical presentation, we don't have a lot of time to mess around with trying therapies. We gotta get in there and get that stuff out of there. So if we can get the secretions into his big airways and help him cough it out, that's wonderful. What we have to consider is we're going to have to do a fair amount of that work to do that because he has this respiratory muscle weakness thing going on. Okay, so they put him on a heated trach mist, which we got to humidify those secretions to get him moving around. And then they talked about, let's see, so I'm just going to read the RT note. Ventilator settings. Actually, first I think I'll read the pulmonary note. I'll read this to you guys. Okay. So the pulmonary note is such. 70-year-old T3 paraplegic, excuse me, with a very weak cough, who's a resident of a care center. He's treated with nightly ventilation. We'll talk about those settings here in a minute. He was recently transferred to the Boise VA for fevers, increased sputum production, and what they thought was a left pleural effusion. So how would we know if it's a pleural effusion versus a infiltrate in that left side? So sometimes we can tell from a lateral film, but we don't have a lateral film on admission from him. So they're going to actually order a CT scan, and I'm going to pull that up for you. So here's just another little bit about him. Trach and chronic nocturnal ventilation settings per notes from his nursing facility are SIMV 16, tidal volume 550, pressure support 10, PEEPA 5, and FiO2 of 35. So we know his baseline oxygen requirements are between 3 and 4 liters, or 35% FiO2. And he came to us on 10 liters hypoxic. So we know that we definitely have something that's requiring him to have a lot more higher oxygen demands, and we could see that on that chest film, that's obviously something going on there. So they don't know. So the note goes to say cough is weak and out of proportion to what T3 or T4 lesion should cause, although he has significant hardware in his left ribs, presumably from prior flail, chest and back, with associated chronic pain, which may limit his ability to fully inspire and generate a cough. So he uses a chronic cough assist. So we know that that's something that we can utilize too to help him take a deep breath in, and then so essentially it pushes air in you and sucks the air back out. So it's a cough assist. You guys know all about it. And possible pneumonia, not clear how much he takes PO, but if he's continuing to take PO meds for a formal swallow evaluation would be helpful. They want to rule out the fact that he may have had an aspiration event. So if you have a tracheostomy tube, you can still swallow pills and food. You just have to let the cuff down. So at night they put the cuff up to ventilate him, and during the day they let the cuff down in the tracheostomy so that he can eat or take his pills, which is great. And so they're going to see how much he takes PO to see if there was a chance that this pneumonia was caused by an aspiration event. Left pleural effusion, it's hard to assess the size of the pleural effusion, so we're going to order a CT with contrast. So I'm going to pull that up for you guys, and we'll look through that real quick on here, which is really nice that we can do. So this is on this is his second day of admission. So his white cell count, I've got this all written, so while this CT is loading, I will show you his lab value changes for the day, for this day. Okay, that's gonna load. And so this is his day 1 of admission. So that's his admission stuff. I guess this would be actually day 2. So his white cell count went to 9.1, red cell count 2.8, hemoglobin 8.2. So these are low. So why do we care about this coupled with hypoxemia? So we worry about his oxygen carrying capacity being low. Also, he's hypoxic. So the amount of oxygen on those very few hemoglobin cells he has is low. So what we need to do is get him some oxygen. And to do that, I think we're going to have to get those secretions cleared out of there. So things we're thinking about his outpatient respiratory medications include a nebulized steroid once a day, and then an albuterol inhaler. And you might say, how can he take an albuterol inhaler to PUFS Q4 PRN if he has a tracheostomy? But they do let the cuff down during the day. So my suspicion is we will be transferring this over to a nebulized therapy here while he's an inpatient. Okay. Outpatient therapies, things we're thinking of immediately. Okay, he came in with what we think is mucus plugging based on everything we've read and what we've seen and the chest film. So we have to think about what his outpatient humidification regimen is. Does he use, are the care facility people using his cough assist appropriately? Are they suctioning him well? Other secretion clearance therapies. Can he do an aerobica or a metaneb? So those are internal airway percussion kind of things. Or do we need to do a vest, which is an external airway percussion thing? So some things we need to be thinking about. What brought him in here? Because when we send him home, we got to figure out what went wrong with this, so that he doesn't end up right back here. So his white cell count's down, which we expected it to be based on the fact that we had this very specific sputum culture and we're able to target these bugs that he had. So good news here, his hemoglobin's down a fair amount, and it actually continues to fall through the hospitalization. So we're starting to think about if he has some place where he has an active bleed, why this is happening, or was he just very dehydrated, got some fluids, and that changed that up a little bit. So we want to know if he's having an active bleed, because actually tomorrow his hemoglobin's only 7.8, and that's extremely low. So we're worried about that. Okay, here is the CT scan. So I'm just going to scroll through here, and keep in mind, so this is a CT scan. So here is the film from that with him laying on his back. So he's laying down flat. So fluid and the likes are going to go along the posterior regions independently. So if you have a pleural effusion, you're going to see it go posterior and independent of the lungs, because it's in the pleural space, not in the lungs. But it's hard to tell until we get in here. So here's your apices. You can see the apice of your right lung is starting to come. And we're a fair amount of distance down that right side before we even see any aeration at all in that left side. If this was a pleural effusion, we would see a water line along here, and it would be posterior. And so we know immediately, and it would be independent of the lung tissue because it's in the pleural space, and it's not. So we know immediately we've got some stuff in the lung, and we've got a lot of stuff in the lung, so much so that we're halfway down the right upper lobe before we even see the left upper lobe. Okay, so here's a little bit of gas exchange, a little bit of air in this left side, but boy, there sure isn't much. So as we continue to go down, it actually gets worse. So and here's our diaphragm coming up, which we don't even see where the diaphragm's coming up on this left side because there's so much mucus in there. So this is quite alarming when you get a CT scan like this, because you've almost got an entire left lung infiltrate, or you want to know if you've got some collapse. It's likely there's some collapse from the mucus plugging, and some of that is atelectatic regions of that lung. So very little amount of this left side is participating in gas exchange. Okay. This is kind of an interesting view. So we know here we're going down. This is the trachea. Right here we get to the carina. Okay, you can see this right main stem branch off, and it's patent. Okay, you see this left main stem branch off, and it's full of something. And so we know immediately that we have got so much mucus in this left side that it's clear up here in this left main stem branch of the lungs. So right after the carina, you see how patent this right main stem is. This left main stem is full of gobbledygook. So there's our CT scan. That's on the second day. When you see something like this, we're not going to rely solely on respiratory therapy to get that out, okay? They're going to do a bronchoscopy. And so you have to go get that. You can't, there's not much we can do to shake that loose and suction that out. When we're suctioning, we're advancing the catheter just to the carina. So if the patient can't get if the patient can't get their secretions up past the carina, past those big airways and past those branches, that bifurcation, we aren't going to be able to get it. So we know he has a couple of things going against him. He's got a lot of secretions in there, and he also has some respiratory muscle weakness. So we can utilize the cough assist. Where I think at this point we're probably going to have to go. Ooh, I touched my face. We're not supposed to touch our face. Very Kleenex. Touch your face only with Kleenex. Then use hand sanitizer. Okay. So after that bronchoscopy, they did which is what they needed to do right away. They did a bronchoscopy. So Dr. Thompson went in with a bronchoscopy. You can drive the bronch right down, and you guys saw two or three bronchs while you were here. You saw how we drove the little camera right down. You can suction stuff out from way further down than we can. So looking at this patient saying, I don't think he's going to be able to get this out on his own. I do believe that we're going to have to go in and get some of that. So they did a bronchoscopy on him, and that was done. Here is that same day. This is after his bronchoscopy chest film. So you can see that after his bronchoscopy, that's about the same. And it looks like things are starting to shift a little. It might be slightly rotated, but it looks like everything's starting to shift over here a little. So we know we've got some consolidation of that lung tissue. When you have consolidation of lung tissue, does it push or pull the mediastinum? You guys already know this, that it pulls the mediastinum over. So you can see everything kind of starting to shift a little bit. He's still got all the hardware. He'll have it forever. And it doesn't look like it's cleared as well as we kind of hoped it would. So back to the drawing board. From a respiratory therapy standpoint, we are going to switch him from a heated tracheostomy to the Vapotherm, and to try and humidify that even better. And he did okay on that. They were able to, let me just read you the note, what they ended up doing here from respiratory. Vapotherm, 20 liters, 35%, 37 temp, and he tolerated that well. His SATs went up to 97, heart rate down to 84, and respiratory rate to 16. So the next day they decided that they were going to repeat the bronchoscopy based on the fact that they didn't have the results they wanted in that x-ray, and he's getting some atelectasis. They're calling it atelectasis in that lower lobe, not just the entire lower lobe filled full of mucus. So it's actually mucus plugging, causing atelectasis and a ton of secretions down there. So they went back in and got it out. Meanwhile, respiratory suctioning out a fair amount of stuff. They're having to suction him about every 2 hours, and one note said copious amounts. And so back to the drawing board with that. Here is, okay, this is day 3 chest film, and I'm going to show you the other one because this is a little more. So complete whiteout. They've got, they're calling this atelectasis of that left lower lung, but we know that he has mucus plugging causing this. So I'm going to read you a report from the, okay, I'm going to go to the reports tab, which we're so lucky to have this. I'm going to go to imaging local, and I'm going to read to you about the CT scan. Just the lung portion, because they talk a lot about everything else except for his tracheostomy tube is patent and medial. There is mucus debris. That's what they're calling this. Okay, that's a lot of it. There's mucus debris occluding the left main stem bronchus. Okay, so if you think about closing off that whole left main stem bronchus, that makes sense with that x-ray we just saw and the CT scan. A small amount of lung tissue remains aerated in the anterior left apex, and that's about all we saw that was participating in gas exchange 2. Mild atelectasis in the right lung base. So it's not only a lot of times when you have a pneumonia on one side that big and that many secretions, a lot of times you'll have bilateral kind of stuff, or he's definitely got some respiratory muscle weakness, which can also lead to atelectasis, which you know. There's complete mucus plugging of the left main stem bronchus. There's complete consolidation within the left lower lobe and consolidation involving the majority of the left upper lobe. These findings are concerning for pneumonia. Severe aspiration could be considered. We talked about that. Underlying malignancy within the left lung is difficult to completely exclude. And then they're talking about mild atelectasis in the dependent portion of the right lung base. So there is some atelectasis in that left lower lobe. So what do we need to do as respiratory therapists? So some things we need to think about for this patient. Okay, he's on nocturnal ventilation. His home settings are, we'll just go over the drawing board here, SIMV with a rate of 16. Oh, there we go. So there's his ventilator settings for nocturnal use only. SIMV, a rate of 16, tidal volume 550, pressure support of 10, PEEP of 5, 35% FiO2. So this patient was ordered on nocturnal ventilation at those settings. So SIMV is synchronized intermittent mandatory ventilation. So what that means is 16 times a minute, whether the patient wants to or not, they get a breath that's 550 milliliters. That's not their only minute ventilation, because they can actually spontaneously breathe above that rate if they choose so or require that. And so it always stays at a PEEP of 5. We talked about PEEP. PEEP is the pressure that's in the lungs all the time after exhalation as well. So it drops down to 5 on a spontaneous breath, and it gives him a pressure support up to 10. So his delta P is 5 centimeters of water, and that's good because that helps overcome the resistance of that artificial airway. So 16 times a minute, he gets a breath of 550 mils. And so that's his baseline minute ventilation, but he can breathe above that if he chooses to do so. And those tidal volumes will vary depending, because it's a pressure support rather than a delivered actual volume of air. I don't want to confuse you with that, but it's a little bit different than anything you guys have learned, but you'll learn all about it next semester. So we want to encourage the nocturnal ventilation. They started him on metineb. So why would they give a patient like this metineb? Well, if you think about secretion clearance therapy and metineb, we need to shake it up a little, I guess. We got to get in there and get that mucus debris. I think that's what they called it, mucus debris out of there. Okay, we know that the antibiotic we're giving is working. But we have to do what we can to get that oxygen into those alveoli. And right now those alveoli are either atelectasis, atelectacized alveoli. Regardless, they're not participating in gas exchange, probably really at all on that left side, except for a little bit in that apices. So we need to get that mucus out of there. So secretion clearance therapies for us include, we could do the cough assist, and the cough assist has vibration, which they should use to deep breath in, suck the air out, move those secretions, help that patient with that respiratory muscle weakness. Metineb, he didn't like it, but they encouraged it strongly. They did metineb with albuterol and duoneb, whatever they could do to, help that mucociliary clearance and to help get stuff way down deep into his lungs and to vibrate and percuss that around. So the combination of the metineb, the cough assist, and suctioning, we were able to do that. Also, they strongly encouraged the use of the nocturnal the nocturnal ventilator because he didn't really want to, but we need to keep that PEEP in there and that little boost to help overcome that artificial airway resistance. I did it again. I touched my face again. Good thing I have hand sanitizer everywhere. I'll wash my hands too. So those are some things that we need to consider. We have to encourage him to participate in his therapies. We have to humidify. So we went from a heated trach mask with a T-piece in the suction there to the Vapotherm to try and provide the very best humidification that we could and to help loosen up those secretions. We had to get him to take a deep breath, so we pushed it in and sucked it out with the cough assist. So that was some secretion removal stuff, and vibration, percussion, all those kind of things that we needed to do. Okay, so I'm going to show you his chest film and all of these things that we did. And here is, let me make it big. Here is his discharge, his x-ray a day before he was discharged. So maybe there's still a little blunting down there and maybe some little areas that there might be some atelectasis in that right lung, but it looks really good, all things considered. And look what we can see over here on that heart border. You can actually see that around that heart border, you can see that costophrenic angle. He still has some gobbledygook or mucus debris, as they called it. Looks like this is a rotated x-ray a little bit, and so his tracheostomy tube's not quite midline, but we're looking like we're getting better aeration and participation from this left lung. So the last thing we have to think about is how do we keep this patient from coming back after this happened to him, right? Well, we've got things to consider. So his therapy was when he came in. These are some things we thought about immediately. Right here. Humidification, cough assist, suction, secretion clearance therapies. Can he do the aerobica? Does the aerobica attach to a tracheostomy tube? Could he do it during the day when he has his cuff down? Is he aspirating? Can he do the metaneb? He's going to a facility. So what does it take to do metaneb? You have to have compressed gas. Does the facility have this? Or should we order him the vest? So manufacturer recommends if you're on metaneb in the hospital, you switch over to the vest for home care or for facility care. And that's primarily, I think, because of the compressed gas issue. But, so we're switching from internal airway percussion to external airway percussion, okay? So discharge plan. Is he getting adequate humidity? How do we humidify his air better? We can't send him home with a Vapotherm, unfortunately, so we have to make sure he has a heated trach mist that he's wearing pretty much all the time. We have to make sure what kind of humidification his home ventilator settings have, because we're pushing all of his air in, and so we got to make sure that his nocturnal, his ventilator humidification is adequate. We have to make sure we adequately humidify his air during the day. Does he have good suction equipment as far as, is it effective? Is the suction going up high enough that we can safely but effectively suction those secretions out? Chest physiotherapy, and this kind of is CPT and secretion clearance. Okay, those are things we have to think about for him. So what are we going to send him home with for secretion clearance? And then was any of the respiratory pharmacology that we gave him sufficient, adequate? Should we add more, take some away? Did it help? Any of those kind of things. So those are some things we need to think about for that. So I will send you guys some YouTube links on doing a cough assist directly to a tracheostomy tube. Nebulizers to tracheostomies is a little bit easier. Metaneb to tracheostomy. So you have to think about the fact that we're not conventionally delivering these airway clearance therapies. We're actually doing the majority of this or all of this through an artificial airway. So things to think about for this patient. If this was helpful, great. If not, let me know.